All right. Well, welcome everyone. Welcome. Thank you, Ann, for being here with me. I'm excited to be doing this webinar with you called Navigating October 1st MDS Changes, Avoiding Common Pitfalls with Practical Solutions. So, Ann, thank you for joining me.
Sure, absolutely.
So,
Glad to be here.
we're gonna dive right in because we know there's people are on their lunch break. People are just hearing us in between whatever it is that they're doing. So, the purpose of this webinar is to discuss the October 1st changes and then how to avoid the common pitfalls that will come with it. This is a continuing education podcast, webinar, seminar. You have to listen to the whole event for the whole hour and complete the QR code or take a picture of the QR code at the back and complete the registration to get your continuing education credits. SMK Medical is sponsoring this podcast. They are a CE provider through the California Board of Nursing. And once again, this course will be one CE credit as long as you stay to the very end and complete the course evaluation. So without further ado, you switch us over to the presentation where we would do introductions.
Great.
All right. So as I stated, this course is presented by SMK Medical, which is a full-service healthcare consulting firm specializing in risk compliance. We do everything from pre-survey, post-survey, MDS completion, MDS auditing, QAPI management, whatever you think of, we can do. We also partner with organizations that do very similar work, and that's where we've partnered with our friend, our colleague, and who is here to really shine some light on her area of expertise, which is MDS management, auditing, completion. So, and tell us about yourself, tell us about your business, and how they can reach you.
Yeah, so my name's Ann Quintana. I've been a registered nurse for quite some time now. Worked through the long-term care circuit, and as Demetrius said, MDS was a prime focus of a lot of my career. And now I own my own consulting company. We're similar to what Demetrius's company does. We work with long-term care and skilled nursing facilities and assisted livings to do compliance management, regulatory guidance, and MDS assistance and monitoring as needed as well.
Now, Ann, you're RAC certified. Am I correct in saying that?
I am, yes. Yeah.
How long have you been RAC certified?
Um, Most recently with the most recent certification for a little over a year now, but I've
Okay.
been certified through other organizations in the past.
Okay. And that's what we want to bring, we want to lean on is, the expertise that your organization, QA Healthcare Consulting and SMK can bring to organizations. So today, once again, it's a 1 CE course designed for entry level MDS nurses as well as experienced MDS nurses. I think this course is going to be great for someone to listen in on their lunch break just to gain additional knowledge and experience. So hopefully you enjoy this, and we look forward to reading your comments about this course. So let's talk about our objectives here. We have several objectives. Our first objective is to review the October 1st changes. As you know, October 1st was here, it's gone. Today's the 9th of October, but we want to talk about those changes. We want you to understand the role of the MDS nurse in generating and optimizing revenue. I know as an administrator, that is one of my key areas that I'm always looking at. How can we increase our revenue? We also want to identify key areas where accurate MDS can increase revenue. Once again, as an administrator, I'm tying it back to revenue. And then we want to discuss how to implement best practices for MDS management. So that is the 4 key objectives, and that's what we really want you to gain from this presentation. I'll turn it over to Ann, and she's going to talk about the key MDS changes that started on October 1st.
Right. So there weren't a ton of changes this time, which is, not the norm for CMS, but still important ones. But there were also a lot of clarifications and new examples that were added to the RAI manual. So I encourage anyone who's listening and actively completing the MDS to make sure you look at those most recent uploads of the RAI manual on the CMS site and look for those changes that can be easily identified because they're usually put in red lettering and italicized print. So make sure you're looking at those, particularly There's some good clarification about when you can code somebody as having septicemia, and also external catheters, since there's been a lot of new equipments and things that have come out that have caused a lot of questions about what should be coded where. So, but the actual item set changes that occurred, they did remove section GG goal items for self-care and mobility. Now, that doesn't mean that you don't set discharge goals for those same things, because that still needs to be done. We're just not coding them now on the MDS, but you'll still need those for care planning purposes and to make sure that residents are have what they need when they're going home effectively. So some new items that were added to section N was about anticonvulsant medications. We're now identifying whether someone is currently receiving an anticonvulsant med. And remember, when you're coding these, it's the medications. It's not why they're on it. It's the classification of the medication that counts. So if it's classified under an anticonvulsant med, you would code it here, even if it's being given for behaviors.
Sorry to interrupt, but you hit something that I see in the MDS group's office. I mean, often, and that is Ozempic. People are using it for various different reasons. But
Right.
how do you code something like that? I think that's a perfect drug. Am I correct?
Yeah, it's a good example. Yeah, it's not used, if it's being used for like weight loss or something, you're not going to code it if that was a coding item, you wouldn't code it as that, because it's a diabetic medication. So, yeah.
Wow.
Yeah. And then you have removal of medication reconciliation items. That was showing up on all the MDS item sets for the discharge ones. And so now they just kind of fashioned it where it's only going to show up on those people who are, when you're doing a Medicare aid discharge assessment and they're going somewhere other than staying in your facility, because you're obviously not going to send a medication reconciliation to the unit next door just because they're being discharged from Med A. And then the other addition was COVID-19 vaccines. So now we're going to indicate whether someone is in an up-to-date status on that vaccine, just like we're doing for the flu and pneumonias. So another way of keeping track of it.
While these things are subtle changes, I think these things greatly impact your QMs and things. Am I correct?
They can, in some cases. Not so much, mostly the vaccination piece of it, they're going to probably be looking at that more now. But that the reporting and the accuracy is the important piece of it. Even if it's not impacting the workflow, the MDS workflow, you need to make sure that your information is accurate and that you're doing the proper follow-up as well. So for instance, if someone's not up to date on their COVID vaccine, the reviewers are going to still be looking to ensure that you offered the vaccine, even if it's just to prove that they refused, that it was offered.
You mentioned a key word, which is up to date. And I think it's important that we talk about what is considered up to date, because, I have my thoughts. You probably have your thoughts, but ultimately the CDC has their thoughts on what's
Sure,
up to date.
and it's ever changing, it seems. So
Yes.
with each new vaccination that comes about, or each new version of the vaccine that comes about, it's changed every time. So right now, as of the assessment reference date for your patient or your resident, up to date means if they've received the 23 or 24 COVID vaccine in the last 2 months, which would have been August or September, technically they're up to date. Now, you're not going to see that on the CDC website, but that's where you've got to kind of read between the lines that if you can't have the new vaccine for 2 months because you just received the last one, then technically you're up to date. But when it comes to the 24 or 25 vaccines that were just released, and some might not be available till this month to your facility, if you've had one dose of either the Pfizer or the Moderna vaccine, you're up to date. If you've had one dose of the 24-25 Novavax vaccine, you're considered up to date, unless it's the first time that you're receiving a COVID vaccine at all. So if you've never received a COVID vaccine in the past and you're choosing to receive, or the resident is choosing to receive the 24-25 Novavax vaccine, they will have to receive 2 doses in order to be considered up to date. Confusing enough?
Well, listen, it's not only confusing for the MDS nurse; it's confusing for whoever's filling out your NHSN, right?
Yeah,
This is you got to understand this because you're going to be putting this information into it. The state's going to reference it, and the state will cite. They're going to come in, they're going to audit, they're going to check because it's an easy citation. If they can find one person with incorrect information, that's at least a D-level citation.
yeah.
Don't let them be able to tie it to a COVID outbreak in your facility.
Oh, dear Lord. Wow.
Now you're at an even higher issue, right? So you
Right.
just want to be mindful of um, how you're coding things, how you're putting things into the MDS, how you're putting things in NHSN. And I think as administrators, because I'm speaking from an administrative perspective, it's important for us to know what the MDS is, how it works. And I know you're getting ready to talk about that next. What is the MDS? How does it work? And what do we do with it?
Sure. Yeah, and the MDS, wow. Where do I start with that? But
Loaded word,
yeah, whew,
loaded phrase, rather.
praise, yes, yes. But I guess I guess we'll just start out with the basics of it. It is a standardized evaluation of the resident's health and functional status. So you're looking at the resident. It's kind of like the resident as a whole in a big, huge document of what conditions they have, what treatments we're providing for them, where they are they declining, excuse me, or improving, and you can see that by comparing one MDS to the next. So it's also sorry, a federally mandated process. It is governed by CMS. They give explicit instructions on how to complete every single question on the MDS assessment itself. You can find that in the RAI manual. And quite honestly, it gives 10 tons of scenarios and examples for each coding instruction. So if you're ever at a question, that's the first place the MDS nurse should be looking for their answers. And then of course it serves several different purposes. It's a payment generator for all payments that you get, whether it's Medicare or Medicaid. It provides a level of acuity for all the residents, so that you know what kind of assistance and care that they need. It helps with care planning for those needs as well. And it can also be used to determine what staff levels are needed. And, oftentimes companies will look at your overall case mix and use that to derive what your PPD would be for the building.
It's very interesting because when you talk about MDS, once again, I speak from the administrative perspective, and I actually teach at a few universities. I teach AITs, right, administrators in training, and there's nothing there. We don't spend a significant amount of time on MDS, but I think as administrators, we have to understand that this is a whole category on our quality measures, right? So, when we look at the nursing home compare, there's health inspections, there's staffing, and their quality measures. This MDS portion directly impacts your quality measures. And if you don't understand this, well, you're probably going to have a challenging time trying to reach 5 stars. You have
Right.
to understand what the MDS nurse does. You have to understand how the MDS assessment and completion impacts those quality measures. So, I not only does it impact revenue, it impacts your quality measures.
Which is, overall overall can affect your 5-star overall status as well. Um, Sometimes
And
for the better if if you're achieving that 5-star quality measure outcome, and that's where your consumers are going to look, to determine or choose the facility that they're going to go to. So it impacts a lot.
I agree with you 100%, right? That's where people are going. They're going to nursing home compare before they come over to your nursing home. And once that nursing home compare, they're going right to those quality measures. They don't understand health inspections. They're reading to it. And obviously, if it's bad, 1, 2 star, they're like, no, they don't want that. But they go right to those quality measures and they know wouldn't say as, return to hospitals and presence of falls and all those different things, UTIs and all
Yeah.
those measures that are up there, they read that and say, oh, whoa, this is you and this is the national average. And they won't come to your facility. So, MDS does a lot, but it definitely impacts reimbursement. So talk to us about how the MDS impacts reimbursement.
Well, first and foremost, if you're putting something on the MDS that's not accurate, you're really shooting yourself in the foot, because it leads to proper reimbursement for the care that you're providing. So you want to make sure that you're taking credit for everything that you're doing. Certain things, certain codes or coding that you complete or that you do will actually change your ranking, like for ADLs, PDPM scores, and just your sections or the areas of the PDPM that you can be ranked into. So the MDS sets a daily rate for your Medicare skilled patients with using those PDPM scores. It also helps with other reimbursement because it provides that quarterly case mix score for each resident. Uh, and then that facility's cumulative case mix score can be used to determine your Medicaid rate. And it's also for some states, of course, if it's not including the PA1 residents, those walkie-talkie
Mhm.
people, as MDS nurses often refer to them, and and then you need to have documented occurrences and backup for those responses that are coded to prevent any kind of take back from that revenue. Because just because they gave it to you once doesn't mean they won't take it back if they find out that something wasn't good.
You know what? You are speaking the language that administrators and owners need to understand. Take backs. You can't just put a head in the bed and think it's going to be great. It's that documentation piece there, and it's also certifying the appropriate patients, because last thing you want is a 5 claims audit, and they take the money back, and you've long spent that money.
Yep. Yeah, for sure. And all it takes is one wrong check box checked, and it null and voids a lot of stuff. And once they find, usually I believe it's a 5% error rate, they'll increase the number of charts that they start to look at. So a lot of times, especially if you're a small facility, you don't have a large
Yeah.
margin for error before it could really impact your overall outcome of that review.
So I think what you just highlighted is the importance of documentation, and from an MDS perspective, right? That's a skilled admission order. That is also your physician certification. That's your daily documentation. That's your updated care plans. I mean,
Yeah.
I'm sure I'm missing something, but
Well,
is that the core of it?
yeah, you mentioned the certs and recerts, and I think we'll talk about that more too. But that's a big piece of the puzzle. If your doctor doesn't have, or you don't provide for them a direction on what needs to be included in that
Yeah.
certification, you're setting yourself up for failure from the get go. So
Wow. So we move through key areas of revenue enhancement through MDS, and this is one of my favorite areas. As a healthcare consultant, I talk to owners, and I can't tell you how many owners or administrators I talk to, and I talk to them about at least the service we offer through SMK. I don't know if you offer something similar, but our free utilization review, where we check to make sure you've captured the NTA points, check to make sure that you've used the right ARD date, you have the right coding. And I can't tell you how many administrators have not taken advantage of that service. I know accurate coding and diagnosis are a must, but it's hard to get them to understand it. So, do you offer a service like that? And then you can lead right on into the importance of accurate diagnosis and coding.
yeah, we do as well. Doing a whole review and audit of the whole MDS and MDS process. We would pick a grouping of um, of people and review those assessments. And the MDS nurses, some, not all, but some MDS nurses also don't understand the real importance of accurate diagnosis coding. It's the what the physician puts in the chart is what the the code you should be looking for. So if the physician isn't specifying their diagnosis as much as it should be specified, we should be going back to that physician and saying, hey, you wrote this, but is it A or B? And then writing a clarification order or having the doctor clarify it in the chart as well to make that diagnosis more accurate. Because the I don't know if anybody's ever looked at the the ICD-10 coding book, but it's pretty specific
Ooh,
on the
ooh.
on those codes, and there's thousands and upon thousands of codes in there that are very specific and sometimes make you refer to another code. So, but being accurate is how it can, why if you're not accurate, that's how it can affect your reimbursement in different ways. So I mean, obviously if you have a lot of managed care is taking over, unfortunately, a lot of people's Medicare benefits, people have elected into those managed care companies, and
Mm-hmm.
in those cases, even you have to make sure that the primary diagnosis that you're using matches whatever the insurance company pre-certed for, even if it doesn't, even if you know in your heart of hearts that that's really not the primary diagnoses that we should be using. You're kind of forced into using it in order to prevent denial of payment. So, and you already mentioned diagnoses being used for NTA points for those PDPM scores. There are certain diagnoses that will get you extra points, and conditions also that will get you extra points that affect that NTA portion of your PDPM score. And we did provide a reference at the end for you, a quick guide that lays it all out of what diagnosis or condition, and then the amount of points that it provides to you and where you would code it on the MDS. So, and then
As
go
a
ahead.
administrator, when I was sitting in the building, I didn't understand NTA. I talk about it, but I didn't understand it. So, you said, like you said, there's some references, but talk to me, a little bit more about that NTA point. You mentioned there's different categories and things, but I don't think we really give the NTA points the praise that they deserve for
Sure.
saving a day and elevating, your bottom line or the revenue you receive for caring for this patient, right? Because ultimately, you get a bundled payment. This is what you get paid per day to take care of this resident. I don't care what happens, but what you have to do is code appropriately so that way you can ensure that you're getting the right revenue to take care of this resident. Because the last thing you want to do is have a resident who requires trach care, or a resident who maybe has a peg tube, IV, and you didn't capture that. So, tell me a little bit more about those NTA points and why they're that important for people to capture.
Sure. So it's non-therapy ancillary points is what the big term would be for that. But so each conditioner or diagnoses has been assigned not by anybody but CMS points as to like, and it associates to how much care and resources are um, do, do, often given to that patient because of that diagnosis or the condition that they have. So it does vary from 1 point to, I can't remember off the top of my head with the top, if it's 8 points or 12 points. It's something crazy, but it's for ones that people don't have very much um,
Yeah.
experience with, or like your ventilators and things like that. But so they're giving you extra credit for those services that would often require more staff assistance or oversight. So it's one way of making sure that they hit that nursing component, as well as giving us credit for the therapy services and things that are being provided.
I think that's a great call out. And, ultimately you're doing all this to make sure, as you mentioned, or you're going to mention, right, you're making sure that the diagnoses are ranking are appropriately so they can pull to that UB04, which is, I know as an administrator, one of my key things to my revenue in my building is that UB04.
Yeah, right. It's a document that not everybody is familiar with unless they know more about the billing side of the MDS. But yeah, that's why people will tell you or preach to you that in section I, you want to make sure that all of those, the top 10 diagnoses are accounted for, and not necessarily just in the check boxes above, but in the write-in portion in the bottom where you're actually entering in the diagnoses code to make sure that the accurate code is being reflected. You want to make sure that your top 10 diagnoses especially are in there, because all of that will pull to the UB.
Great
And
information. I mean,
yeah, one
go
other
ahead.
thing about the diagnoses too to remember is that you want to make sure that you're creating a new diagnosis sheet each time you do an MDS, so that the most accurate and active diagnoses are being pulled to those billing reports.
Great information, as I was saying, and all of this leads to, once again, revenue. And as an administrator, that's something that I care deeply about, is the revenue. Because I don't know if people see my other webinar I did for the HCHCA, where my focus was on census, budget, and compliance. And if I don't have budget, I can't maintain compliance, and I won't keep a census if I can't maintain compliance. So the purpose of this particular webinar that you're on right now with me and AQ is really to talk to you about the changes from October 1st, as we've done, but also to really enhance the revenue, avoiding some of the common pitfalls that we have both seen as healthcare consultants. We walk into nursing homes every day helping facilities improve their quality measures and increase their revenue, and we wanted to share that information with you guys. And Ann's going to talk next about timing and documentation, because this is something that we see time and time again.
Yeah, I mean, what more important things can you have for an MDS but to be done at the right time and have the documentation to back up what you're putting on the document? AR setting the assessment reference date, what we call ARDs, to capture any nursing care or therapy participation that was being done is pretty important. And even though we can't really get much out of the hospital paperwork nowadays, you still need to be reading all of that paperwork to make sure that you're not missing something that was in there, particularly IV fluids for hydration. That's pretty much the big ticket one that we can capture if it was given in the last 7 days, even if it was in the hospital. So that's where you want to make sure that you're not setting your in-house assessment for day 8 when the resident received IV fluids for hydration all the way through the end of their hospital stay. And then, of course, accurate documentation of clinical conditions and the services that you provide. We can't just assume that, the person has COPD, so obviously they're short of breath. That doesn't always go hand in hand. And so you
This is
actually have
true.
to you actually have to have documentation that the resident is short of breath when they're lying flat, whether it's you ask the patient that information and you document it, the aides are documenting it. It's got to be somewhere. You can't just make that assumption. Aerosol treatments, it's still important to record the minutes of therapy that was provided, including your pre and post evaluation or assessment of the resident, and the monitoring during the treatment. And then most importantly is ADL documentation and making sure that it matches what you've coded on the MDS. And that's probably one of the hardest things to do, because it's hard for staff to understand what the coding means. I feel like it's gotten a little bit better
Yeah.
with the PM definitions versus, when you're looking at section GG versus section G, it's a little bit more understanding, only because it's more descriptive, but there's also more options, which gives you more room for error. But making sure that what you're coding on the MDS matches the documentation, even if it is you being the MDS nurse having to write your own progress note about your interviews that you did with staff. But it is still important that interviews are completed and documented during the look back period.
I think what you've highlighted on, and I've touched on as an administrator is, we have to capture this in the documentation. But what we can't do as owner operators, administrators, executives is put everything on our MDS nurse. It is called an IDT team for a reason. So we are a team, and maybe that's the nurse and me whistling through the administrator's body, but we're an IDT team.
Right.
And my nurses can't be doing it all by themselves. I love that to happen if they had the time, but I doubt they have the time, because if they're sitting down writing the notes and doing every single thing, something's going to fall off the plate. The plate's
Right.
only so big.
Right. Right.
So,
Right. We don't want leftovers. We want it all first helpings. So, but yeah, and I think from an administrator, like your role could be to help ensure that you have the best assessments out there in the computer for the floor staff and for the other departments, to make sure that they're capturing what they should be capturing in their
mhm,
assessment documentation. It's always helpful to have kind of guidelines to document by. And a
definitely.
lot of the computer systems out there have like the pre assessments that you're opening up an assessment and you're completing them by answering the questions and checking the boxes, and those kinds of prompts for certain things like shortness of breath when lying flat is are huge are huge. So we talked
Absolutely. I
about
think,
revenue enhancement, and if you're doing improper date setting or you have a lack of documentation, you could miss a score from the get-go. But kind of worse, is the take back in the end. And we kind of talked about that a little bit. Those reviewers come in and they're comparing this MDS based off of the ARD to what the record reads from that ARD through the look back periods. And if you checked a box on the MDS that isn't justified or backed up by what they're looking at in the record, that question becomes null and void. So if that question actually affected the where your assessment was ranked, the PDPM score, then that portion of that score is going to be removed, and which
yes.
then will lower your overall reimbursement for that patient.
All important facts to enhance revenue. And if you're an administrator or healthcare executive, this is your slide. You want to make sure that you're listed in. But as quick as I say that, right, we move over to what I think is something that's key, and that's you're going to talk about therapy and auxiliary services, but my favorite part is part B, right? Making sure what needs to be billed is billed out on the part B. But I think administrators miss that. Owner operators, they miss that. They think we get that per day rate. We got to do everything out of it, but there are some carve outs. There are some carve outs. So talk to us about therapy and part B and this screen we have right in front of us.
So, documenting therapy minutes, obviously, and those services correctly, um, are very important in order to capture the full extent of your reimbursable care. The therapy time is not cheap. I'm sure as an administrator, you're more than well aware of that. So we want to make sure that we're getting reimbursed appropriately for the time that they're providing. So we want to make sure we're capturing the days appropriately and the total minutes on those end assessments, especially. The therapy section has become a lot more difficult to navigate than it used to be. So I really encourage the MDS nurses, or if it's that you have your therapy staff who are completing those sections, excuse me, that someone's making sure that the numbers and the numbers that are being entered, whether it be days or minutes and total minutes, are done accurately. And then don't forget about those speech language diagnoses and factors that affect that component of the PDPM score. Sometimes I think people forget that there can be kind of two sections that come together, that you have to make sure that it's marked in one and marked in the other. As an example, is if the person has a diagnosis of dysphagia and they are on a mechanical soft diet. But if we don't mark that mechanical soft diet, we just threw our score out the window for that. So, and then of course your favorite, Part B. So my recommendation has always been um, all residents should be on a quarterly screen for to see whether they require therapy services. And I'm a believer in not doing things twice if I can avoid that. So I always had set up for any therapy company I worked with to screen residents 2 weeks prior to what my ARD was planned to be. And I, never push it out to the 92nd day. I always moved dates a little bit forward to avoid those having to redo assessments unnecessarily. So those Part B screens can be very helpful by making sure residents are picked up to either prevent an occurrence of a decline and to just enhance the care that we're providing to them as well.
Favorite section. I love the quarterly screens. It is the favorite. Listen, because it's so much that can be lumped under there, and oftentimes we're paying for stuff that we just don't have to pay for. You have to partner with a good DME company to really capture those Part B things, and therapy company and all that great stuff. But it's something that if you're not investigating, you should be investigating as an administrator, as a healthcare executive, because revenue is one of our main jobs, right? It's one of our key KPMs. And, I would list it as a best practice. You're going to talk about additional best practices, but I think that's a best practice for me as an administrator.
Mm-hmm. For sure. Yeah. But as we see here, one of my big things for best practices is training for the MDS coordinators. I mean, there are lots of great nurses out there, don't get me wrong, but sometimes pulling someone off of the floor who's a great nurse and just throwing them into an MDS role and expecting them to figure it out, not the best practice if you want to maintain your reimbursement levels and accuracy. And obviously, certifications are out there. They're a plus, but they're not required by any means. But the one nice thing about if you do get a certification and you belong to a group or a certified company like that, they are offering ongoing education all the time that keep you up to date with all these regulatory changes, kind of like we're doing now. But I always recommend that the nurses actually read the RAI manual, not just listen to Mary Jane, their partner in crime in the office, telling them how to code a section, because Mary Jane's interpretation might not be exactly correct.
Yep.
But the RAI manual is, and that should be their Bible. So.
Well, you mentioned some regular training. You can't just pull them off the floor. I can't tell you how many times I speak with administrators, owner operators, and I see you have a position open in your facility, and I call and say, "Hey, we can fill you at a much economical rate than just pulling somebody off the floor." Because when you pull somebody off the floor, now you're short. Now you're
Right.
paying overtime, and then
Yep.
you put somebody in that seat, and they don't know what they're doing, so they're not coding appropriately. You're losing
Sure.
money. They may be opening an assessment late. You lost money. I mean, it's the cycle goes on and on. But they say, "Hey, I just got somebody." No,
Yep.
a
Yeah.
body is not a body, and I think we got to get out of that mentality. Soapbox as an administrator, we just can't pull them off the floor.
That's my soapbox as an MDS nurse background as well. Director of nursing, MDS, doesn't matter. I'm in favor of making sure people are well equipped to do the job that you're asking them to do, and they'll do a good job at it if they feel comfortable at it. So, big point for me: education, education, education. So, and then of course, internal audits and quality checks. Conducting regular audits to ensure your data accuracy, whether you have internal people who can do that or people like you, Demetrius, and myself that come in and just do some random audits of accuracy. I've seen a lot of citations lately increasing for that because the surveyors, when they're coming in, are cross-referencing stuff, and the second place they go to look is the MDS. And what did the MDS say? Oh, look, that they had a fall on the 11th of last month, but it wasn't coded on the MDS that whose ARD was yesterday, and it's been within 30 days. Oh, look, that's an easy find. And I'm a big proponent of not putting things out there that makes it easy for the surveyors. um, so collaboration across departments, you already touched on that a bunch about this is
Yeah.
an interdisciplinary teamwork,
A
an
100%.
interdisciplinary document. So it takes a village, not a person, to make sure that the MDS itself is accurate, and also that what we're documenting is consistent and congruent with um, the residence chart and what you see when you're walking out on the floor and observing.
100%. I think when we talk about, the best practices that you just outlined, um, you're 100% right, right? Regular training for the MDS nurse is needed. Internal audit checks and quality checks. If you don't have the means to do an internal, right? Maybe you're a small facility. That's why I'm on this call. Ed's on this call, right? Maybe you're a small facility. We can support you. I work with so many small facilities that don't have a regional. So if you're trying to check the work that you did, but you don't know what you're doing, what are we really doing? And
Right.
if you're saying we are our best selves, but we're a 2-star, are we really doing ourselves a service to see if we have revenue walking out the door? I got a spoiler alert for you, and we have a case study coming up next. You can be a 5-star and still allow revenue to walk out this door. I've surveyed and assisted 5-stars and realized all your members are what, PA1? Is that how I say it? Did I say that right? Did I say that right?
Yep. Yep.
Right? Which is what category? Is that not the lowest?
The lowest that you get just
So,
a dollar amount per day that won't barely feed them of 2 meals.
but you're 5-star. So
Yeah.
just because you 5-star doesn't mean you're maximizing your revenue. I've been in one-star buildings, and their hips and her scores were through the roof. Their daily rates were through the roof. So please don't be distracted by the star level that you get, meaning the quality of revenue you're bringing in or the amount of revenue that you're bringing in. That is not there's no direct correlation in essence, right? Because once again, you can be a 5-star but be a PA1. And then
Right.
that collaboration across departments, right? As a nurse, as an administrator, I need the IDT team to work together. This is no one person's job. This is no one person's task. This is
Right.
a IDT team, and we're not only doing it for the resident, we're doing it for the organization. The organization needs us to work together as a team in order to capture all of the reimbursements that we are due. And over the course of my time, I've had the pleasure of just working with buildings and seeing some of the issues that they have. And we've compiled some examples here. And we'll talk about some, I'll talk about some, but we were able to compile some of the things that we see that are common in buildings. So, and I turn it back over to you to talk about some of the case studies.
Yeah. I'll tell you, there's a lot out there, but these are just common ones I think that are kind of easy to be repetitive with, and things that I've seen being done more often. Is, and we kind of talked about it a little bit already, was a resident being admitted with IV fluids that weren't captured. They had IV fluids for hydration in the hospital, even up to the day of discharge, but the nurse might have not reviewed all of the records, and there was a case one time where it wasn't on the flow sheet, like the medication record that came over from the hospital, but it
Mm-hmm.
was clearly documented in the dietitian notes and in the physician notes. So it's really important to read every piece of information that you're provided and ask for them if you think that you're missing something. Um, and oddly enough, sometimes it's the therapy notes where you find a lot of good stuff, because
Yep.
good thing therapists are often very good documenters.
And so the next one, right? Resident admitted on the skilled services, but there's no physician certifications.
Right.
Please, we got to stop that.
And like I said, there's, go ahead, I'm sorry.
No, go ahead. Go ahead.
And say, like I had said too, there's specific things that have to be included in order for it to be considered a physician certification. And the easiest thing, in my opinion, is to provide them with a form that kind of lays that all out there. And on that form, we, the facility staff, can complete a lot of it so that it's very specific about the services that are being provided and the length of time that's being provided and the discharge expectations and planning for it.
Hmm.
But the most important thing is when the physician does it or reviews it, the physician or nurse practitioner has to sign and date the form themselves.
Yeah.
If they're signing the form and you're dating it, especially if your pen is pink, because God knows nurses for some reason like to use odd colors on documents,
Yeah.
that can be just denied just for the sheer fact that the physician didn't date it, that we're dating it for them. And
You
then, of
know,
course, the timing of those certifications are hugely important. And the form can usually gives you a guideline to the left on when those signatures are required if you don't know that off the top of your head.
so and to your point, right? Date and signature are the key items that need to be on it. And one of the things I'm checking for as an administrator is having my MDS nurse do physician cert audits to make sure. And we're going to report that off into QAPI if it becomes an issue.
Sure. And I can tell you too that even the managed care companies are looking for those. Even though it's
Yes.
a Medicare requirement, the managed care companies have come back and said, "Oh, well, you didn't have a certification, so we're going to take back that payment as well." Um, the last example there was failure to review records to capture NTA points, and we kind of hit that nail on the head already
Common
with
practice.
yeah, yep,
It's
misdiagnosis and conditions, extensive services that were provided. Yeah,
that's a common practice that we see as we go into buildings. And here's the deal: buildings, you don't have to do that. You don't have to deal with that. You have services out here, such as myself, such as Ann's company, who will work with your organization to ensure that you're maximizing your NTA, ensure that you are setting ARD dates, whether it's on-site auditing, on-site training, remote training. We're here to assist you. We really want your organization to be great. We want to see you thrive at that 5-star level, and we want to see you thrive from a revenue perspective, because we know when you have more revenue, you have more revenue to take care of your residents and the staff that's providing the care to those residents. So let's talk about some implementation strategies here. I know we have roughly about 6 minutes left before our time is up. So let's talk about some of these implementation strategies, and then we'll take it to the final thoughts.
sure. Yeah, there's lots of different things that you can do, and I know that being an administrative nurse and corporate nurse for a long, long time, people get meetinged out. So the if the more concise and productive you can make a meeting in a short period of time versus dragging it out for 2 hours, the more productive everybody is. So a lot of people use Medicare meetings. Which is sometimes referred to as a utilization review type of meeting, and they're usually doing those at least weekly. In my history, we've done them on a daily basis and just have briefly gone through people and talked about like what skilled days they're on, what their skilled services are, what the projected discharge dates are, and at the same time, clinical people can bring in if there's anything going on or coming up with that patient that the MDS nurse might not be aware of, and or therapy might need to know in order to make sure that they're able to get the best out of the patient on that day or with what's coming up. Especially talking about appointments when the resident might not even be in the building and available to do therapy. They can adjust their times so that they don't miss a day and end up missing what they need to capture from maybe minute wise or days of therapy that would be required to hit your categories. And then triple check is always a big thing once a month, that you're going back and checking everything, checking that things are there that you want to make sure are in place before your billing goes through. Then you have did you want to say anything about the triple check? I know you're a big triple check buff on that.
Listen, I'm a huge fan of the Medicare and the triple check, and at the end, so I believe you have to do them. It's just no ifs, ands, or buts. But I know sometimes people have other thoughts on it. But I believe you have to do them. I did a whole presentation on it with CBC. You can check it out on our website. But you have to do Medicare triple check. And at the end of this, I'll flash a QR code on the screen as well, so you can get access to our free tools. You just register, sign up, yada yada yada. We don't sell your information, but we will give you access to our free tools. And in that, we have a Medicare meeting checklist. We also have a checklist for triple check as well.
Yeah, and so at-risk meetings, some people call them wounds, weights, and falls meetings, just
Mhm.
your risk meetings, uh, so that you know that you're making sure that you're keeping an eye on those high-risk patients, people who've developed pressure areas, people who are experiencing weight loss, and hopefully capturing that before it becomes a significant loss for them. Looking at people who had fallen and making sure that appropriate interventions are in place to prevent falls or prevent injury for a resident, because obviously we can't always prevent a fall, but trying to make sure that they're the safest that they are is our best practice. But looking at those things and making sure that we're capturing things we want to capture, and or maybe adjusting a date so we don't quite capture it just yet, and we avoid capturing something that is reversible. Just managing all of that process. And then you want to ensure that you have also responded to these October changes. Like I said, there's not a huge amount of them, but there were some good clarifications in the RAI manual that you can refer to make sure that if you had any questions about things you were coding previously, that see if
Mhm.
they've been now clarified for you. And then, of course, accurate assessments and timing of assessments, opening the right assessment at the right time, especially your
So important.
interim payment assessments. I mean, if something is there that is going to increase your reimbursement, open it because that reimbursement changes as of the ARD of that assessment. So you want to make sure that you're capturing it as soon as you can. And then, of course, we said it again: diagnosis coding, training, education, updating and removing diagnoses, making sure that it's an active diagnosis. Uh, it had to be documented on by the nurse practitioner or physician um, in the last 60 days to be considered active, whether you have it as a simple signature thing that they're signing a paper, that they've reviewed them and that they still remain active, if it's on the medication and order requisitions and they're signing those on the monthly basis. Whatever it is, they still have to acknowledge that it's still an active diagnosis for you to code it on the MDS.
Man, implementation strategies to not only improve your quality measures, but also to improve your revenue as a facility. As we get ready to transition over to our final thoughts, I wanted to put that QR code on the screen. You scan that QR code, it takes you over to our website where we have a plethora of free tools, including our triple check form, which is a fillable PDF, might I say. It's also our Medicare meeting form. We have our physician certification form, which is a fillable PDF. So many tools there that are free for you to take and improve your revenue and ensure quality care is delivered. And lastly, improve your quality measure. So, and I appreciate it. Sharing your wealth of knowledge and because you have that knowledge, you have that expertise that facilities are looking for to strengthen not only their compliance but also their revenue as well. So uh, as some final thoughts, right? I need administrators, owner operators, MDS nurses, right, to review and apply the strategies that we discussed here during this webinar. It is important for accurate MDS management, accurate diagnosis, as well as helps you capture the revenue that you deserve. You can maximize your reimbursement by focusing on precision and documentation. And you mentioned it, right? If we are just putting anything in documentation, it doesn't mean that we're going to capture what we need to capture those NTA points. It doesn't mean because we're documenting, we're capturing the therapy notes or the therapy minutes, respiratory minutes, right? We need to make sure that what we're documenting is appropriate for that resident at the right time. Am I correct?
Correct. Yeah, very important. Very important.
You can also utilize our cheat sheets, or our sheets that will help you become compliant, which is our triple check sheet, as well as utilize other resources such as the one that SMK has, which is mdseducation.com. Not only that, you have access to myself, you have access to Ann, who are experts in the field who can help your organizations thrive. And you can also implement a system for continuous auditing, a continuous monitoring. Some would call this that QAPI process, but I would say that triple check meeting and that Medicare meeting helps you with the continuous monitoring and auditing so you don't have any issues. Last thing you want is a 5 claims audit and realize that your processes were not in place as they get ready to do some take backs. And then lastly, once again, you can contact us for further support. So once again, that free tools placard is on the screen. You just take out your phone, you scan it. Now, for our people who are listeners and maybe driving in their car, maybe they're sitting at their desk, but they're not looking at the screen, you can visit our website at smkmed.com, click the free tools section, and register for access to those free tools. And as we get ready to close this out, how can people reach you?
I have a website that is accessible. It's qahealthcareconsulting.com. They can email me at info@qahealthcareconsulting.com or call 440-201-9466.
And tell us again, what are the services that your organization offers?
So again, we provide assistance to long-term care facilities, assisted livings, and hospice companies for regulatory compliance, reviews, reimbursement assistance, including completion of the MDSs, reviews of the MDS, mock surveys. I'm also a CPR instructor, so those are other things that we can do in addition.
Listen, we're so grateful to have you here on this webinar seminar with us for lunch. My name is Demetrius. I am a senior consultant with SMK Medical. We focus on all things long-term care consulting, from mock surveys to PDPM audits to MDS audits to plan of correction development, post-survey, pre-survey. But that's not all. Like Ann, right? I am a CPR instructor as well. You can visit us on our website at smkmed.com. You can call us directly at 313-314-8267. Now, I think to the most important part that people want to know, how do I get my CE? I've sat through your webinar. How do I get my CE? Well, you get your CE by clicking the link in the description and filling out the form, the course evaluation form. Or if you have your phone in front of you, you pull out your phone, you take a picture of the QR code that's up there, and that QR code will take you right to our course evaluation. Once you fill out that course evaluation, we usually send your CE roughly about 7 to 10 business days after we receive your information. Once again, you've had to listen to this full presentation and provide feedback through this course evaluation form. Once you provide feedback through this course evaluation form, we will send you a CE. Our goal is to educate the masses. We want to educate not only MDS nurses, MDS coordinators, we want to be able to provide support to regionals, regional RDOs, regional clinical nurse, right? We want to be able to provide support to the administrator, the owner, operator. If you have any questions, you can reach out to Ann at 440-201-9466 or me directly at 313-314-8267. Ann, I appreciate you for taking time out your day to do this Learn Over Lunch with us.
Yeah, thanks for inviting me, Demetrius. I appreciate it.
It has been a pleasure. This QR code is right up there. QR code is right up there. And if you're listening in your vehicle or you're listening anywhere and you can't see the QR code, that QR code will be in the show notes. If you have any questions, you can email us directly at info@smkmed.com.